All right. Thank you again for joining us for this monthly medical review errors and issues webinar. My name is Mary Sue Gardner, and I'm going to be your instructor for today's course. Now, I'm joined today by Rachel and Jennifer, who are the other nurses on the Provider Outreach and Education team, and they're going to be assisting me with the question and answer portion of today's call. There's other members from Provider Outreach and Education on this call as well. If you have questions at any time during today's event, please place those questions into the chat and send them to all panelists. We're going to do our best to answer all of those questions during today's event. But if we can't, we'll send those questions and answers out to you via email after the event is complete. Finally, if you experience any technical difficulties, please email us at wps.gha.education@wpsic.com. We have someone that's monitoring that mailbox during this event that will be able to help you. There we go. So on your screen is our disclaimer, and we show this disclaimer during all of our live events. And the gist of our disclaimer is that Medicare rules and regulations are what we use to build this event, but the Medicare rules and regulations often change. So the information that we're providing you today is current with today's Medicare laws, rules, and regulations. If those change tomorrow, it's your responsibility as a provider to make sure that you are following the rule changes for your current dates of service. Now, Medicare also prohibits you from recording this presentation for profit-making purposes. So if you are recording or doing screenshots, we ask that you please stop doing that because we don't know if you're using it for profit-making purposes or not. But we are recording this event for you, and it will be posted on our YouTube page as an encore for today's event. Now, Medicare's full of acronyms. So in your slide deck, and as shown on the screen right now, is a list of acronyms that I may or may not use during the course of this presentation. So if I happen to use an acronym and you don't understand what it means, just go ahead and refer back to this acronyms list and, find out what it is that I intended to say. Before we discuss the overall objectives and agenda for today's event, I want to highlight that the vast majority of the pre-submitted questions that we received really wanted a general understanding of when to use the KX and about the documentation to support it. So my overall objective of today's call is to equip you with that knowledge and the tools necessary to ensure proper billing and compliance with outpatient therapy services so you can be sure that you're using that KX modifier correctly. And I hope to achieve this objective today by discussing the KX modifier and its purpose in outpatient therapy. We're going to be reviewing how and when to report the KX modifier in therapy services. And I'm also going to highlight common documentation errors and areas of concern upon review of these services so that you can avoid these errors in your practice. The focus of the event is to cover the use of the KX as it relates to rehabilitation therapy services, such as PT, OT, and SLP. We did host a Modifier Monday event back a month or so ago that covered using the KX with other services. If you have questions on the use of the KX with other services, we do invite you to watch the encore recording that's posted on our YouTube. And it looks like Rachel has put a link to that YouTube video in the chat for you. But if you need it at a later time, you can always go to YouTube and you can go to our Encore playlist and find that at any time, or do a search just for KX Modifier. All right, we're going to start by defining the KX modifier. And the KX modifier in outpatient rehabilitative therapy services is a billing modifier. It refers to an annual per beneficiary incurred expense amount for therapy services. When this billing modifier is appended to an outpatient therapy claim, you're really attesting to the fact that the services are medically necessary. So the services being provided by the therapist are actually medically reasonable and necessary for your patient. By appending this modifier, the therapist is indicating that although the patient has received therapy services that have met the yearly threshold amounts, continued care continues to be medically reasonable and necessary. So again, not only is the therapist attesting to the fact that continued services are medically reasonable and necessary, they're also attesting to the fact that they are maintaining all the required documentation to support the medical necessity of the services. And so as we, your Medicare administrative contractor, review some of these claims that happen to contain the KX modifier, that's really part of the component that we are looking at. We're looking at that documentation that you are providing us to make sure it's supporting the medical necessity and continued medical necessity of your service. So a little bit about the history on the use of the KX modifier for therapy. On February 9th of 2018, the Bipartisan Budget Act of 2018 was signed into law. And one of the provisions of this law was regarding Medicare's payment for outpatient therapy services. This included physical therapy or PT, speech language pathology or SLP, and occupational therapy or OT. So Section 50202 of the Bipartisan Budget Act repealed the outpatient therapy cap and exception process, but it did add limitations to ensure payment was still made for appropriate services. So what does all this mean? It means that the former therapy caps and exception processes are gone. We refer to these amounts now as thresholds. So the KX no longer represents an exception request, but serves instead as a confirmation that services are medically necessary after the beneficiary has exceeded those threshold incurred expense amounts. So let's talk about those thresholds. And again, as they relate to the outpatient rehabilitative therapy services. So first, there are two threshold levels. The first, or the lower dollar amount of the two, is called the KX threshold. So you can see that on your screen, or if you're following along with this slide deck, under the KX thresholds for 2023 are listed. And those KX threshold amounts are $2,230. So PT and speech language are combined, and OT stands alone. So $2,230 used in physical and speech language combined, and $2,230 in OT. So outpatient providers need to monitor your patient's eligibility for your patient's eligibility records to make sure that you know when you need to start appending the KX modifier to the claim. The second threshold amount is the manual medical review threshold. And this is the upper threshold amount, and it signifies that services in excess of this amount are subject to manual medical review. So the monetary amount for the threshold is $3,000. That's $3,000 again for PT and SLP combined, and $3,000 for OT. And this amount is going to remain unchanged until 2028. And that time, it'll be indexed annually by the Medicare Economic Index. Now, the lower threshold amount, that threshold amount will change every year. And you can see I have it listed here in your slide deck that the threshold amount for 2024 will increase to $2,330. So it's $2,230 right now. In 2024, it will go to $2,330. Again, these limits are based on an incurred expense, and it includes any applicable deductibles and coinsurance. So when you're verifying the threshold amounts used by your beneficiaries, it's the incurred expense, including those deductibles and coinsurance amounts. Let's move on and talk about when you append these modifiers to your claim. So you add the KX modifier to the outpatient therapy claims, and remember this is only for the outpatient therapy claims, to indicate that you are attesting to the fact that services are going to be provided to your beneficiary and they continue to need services even though they are at or above their yearly threshold amount. You're saying that the services continue to be medically necessary and that the documentation in your patient's medical record is going to justify those services. So this includes documentation that, the patients, based on their condition, require continued skilled therapy. And again, that's therapy beyond the amount payable under that threshold. And they need that to achieve their prior functional status or maximum expected functional status, and it needs to be within a reasonable amount of time. The use of the KX is not limited to rehabilitative therapy. It includes any medically necessary outpatient therapy services, including maintenance, that are above and beyond the threshold. Also remember the GN, GO, and GP therapy modifiers are also required. So providers would append those modifiers to each line as well. Providers can report the modifiers on the claim in any order. If there is insufficient room on a claim for multiple modifiers, additional modifiers may be reported in the remarks field. There is additional information in the Claims Processing Manual, which is 100-04, Chapter 5, specifically Section 10.3.3, on the use of the KX modifier that can assist you when reporting it on the claim. And I'm going to have Rachel go ahead and put that into the chat, but it is also in your resources. So again, you append the modifier when your beneficiary's incurred therapy expense amount qualifies for that lower threshold. And when they're at or going to be above, you really want to start watching for services. And, it's okay if it gets appended a little bit early because you're unsure maybe about an exact amount that's been used. So it's better to append it maybe a little bit early than it is to append it late. So where do you check for the therapy amounts used? If you are checking eligibility through the provider portal, you're going to want to go to wpsgha.com. You're going to log into the portal using the user login information from any of our pages. And once you're logged in, you're going to want to do an eligibility check. So eligibility check allows you as a provider to verify certain information that Medicare has on file for your beneficiary. Eligibility information comes from the HIPAA eligibility transaction system, or the HETS eligibility transaction. And the information available in the portal is the same information that's provided by the interactive voice response system, or the IVR. It's important to understand that while eligibility information is accurate at the time it's given, the information may change if Medicare or any federal agencies that supply data to HETS, such as Social Security or something like that, if they receive any additional information. So although the data from the HETS system is up to date and in real time, data comes in from many different sources, and it may take up to a week or two if something were unfortunately to come in from a different system. So Medicare contractors process claims based on the information on Medicare's file at the time the claim is processed. And again, you can access eligibility by clicking on the links under the My Transaction heading in the menu. And I'm going to actually take you out to the website and kind of show you a little bit of the information. Now, all right, let's back up here a bit. Let me pull up the website. And we are going to go here. And let me make this larger. Now, I can't log into our secure side of our portal. I'm prohibited from doing that. But as a provider, if you have access, you can log in. But the one thing I want to show you is where this information is in our portal manual, in case you haven't gone in and looked at it. So and I'll start at the beginning again. When you first come into our website, you're going to want to choose your jurisdiction that you represent. If you're J5 Part A, J5 Part B, J8A, J8B. I just default to J5A. I'm going to go to the portal user manual, and there's a link right out under the login. You, as a user, would go ahead and log in, but I'm going to want to show you where to find these instructions that we're talking about. So I am going to then scroll all the way down in the manual to eligibility check. All right. So this is where I'm going to find the information about accessing and doing eligibility check. So as you scroll down and read under your My Transactions, when you're logged in, you would want to go into the eligibility check information. It's then going to ask you to put in the information regarding who you want to do an eligibility check on, who the beneficiary is, and the dates of service in question. Once you append all of this information, you're going to click on the eligibility. Now, for our purposes today, we want eligibility information on what continues to be known as therapy cap, even though it's a therapy exception process. So I am just going to scroll down. You can either scroll down or there was a quick link listed above. And this gives you additional information about, you know, what you're going to see once you click on the therapy cap. All right. So again, that section of the manual that we just showed you really is going to help walk you through that. And I know I kind of went through rather quickly, but you can always refer back to it if you need information on that. All right. Now, when checking the IVR, or the Interactive Voice Response System, you will call into the specified number for the IVR, and when you're prompted, it will say, okay, in a few words, tell me why you are calling, and then you would simply say eligibility. You want to speak as clearly as possible. You're going to need to authenticate yourself by using your billing NPI. You're also going to have your PTAN and your tax ID. So once you're authenticated, it's going to take you through a series of prompts to find that eligibility information. So you'll need to have the Medicare beneficiary's Medicare number, their name as it appears on their Medicare card, their date of birth, and the date of service. So again, if you're using the IVR, make sure you have all that information in advance, and make sure you have your NPI, your PTAN, and your tax ID before you call in, as well as the beneficiary information. And probably, and most importantly, before starting your outpatient therapy services, you should always ask your patient if they have received any other therapy services this year through any other providers. Remember, providers have 1 year to bill their services to Medicare. And if you know there's services that were already used, but maybe not appearing or maybe not billed, you may want to check with that other provider. And you will definitely want to be checking either the portal or the IVR for that eligibility information, and continue to check it frequently. Remember, it is okay to start appending that KX modifier a little bit early, but you don't want to, you know, wait and get into a situation where you're far beyond their yearly usage before you start appending it. And you also don't want to just say, okay, at 80% of the patient's use, every single time I'm going to just append the KX modifier so I don't get myself into a situation. It doesn't work like that. You should be checking frequently, and when you know you are getting right before or at that amount, then you start appending, and you keep appending once you exceed that amount. So who must report? Well, reporting it applies to every outpatient therapy setting and every outpatient therapy provider in any kind of private practice. So if you work for a physician's office that does therapy services, if you are a freestanding private practice therapist, if you are Part B of a skilled nursing facility, if you are doing home health therapy services, any services provided in a hospital outpatient department, or CORFs or ORFs, or anything that's considered outpatient therapy services. And remember, we specify outpatient therapy services. And when you think about those and the billing of those, I don't want you to be confused by services that are provided in a hospital outpatient department, but the bill still goes to Part A. Those are still outpatient therapy services. Even though your bill doesn't go to Part B of Medicare, it's still an outpatient service. In the industry, we call them B of A services. That's not a real term, but it's a way to easily think about outpatient services that still need to be on a Part A claim, even though they're outpatient, because they were rendered from an outpatient department of a facility. So that's kind of the key word to keep in mind. If it's an outpatient of a facility, then it is an outpatient service, but it goes through the Part A bill. Hopefully that makes sense. If it doesn't, just put a question in the chat and we can walk right through that again. So at this time, I'm going to pause and see if there's any questions that have come in regarding anything we've covered at this time. So Rachel, have we received any questions?
No, at this time, we have not gotten any questions in the chat.
Okay, perfect. And I'm going to continue on, and that doesn't mean you can't append questions to the chat. Go ahead and please do that. And we have lots of opportunity to take those questions. We're going to move on to some of the common review findings. So let's get into the issues that medical review is finding when they review therapy services that contain the KX modifier on the bill or on the claim. Just so you know, these findings are not necessarily on the actual appending of the KX modifier to the claim, but instead on the therapy services provided that require the KX on the bill. When medical review is performed, we have to make sure that it is, that what's billed matches what's in the documentation. If your documentation doesn't support what's billed, we can't pay you for those services. So in general, when we look at therapy claims that have gone into the usage amounts that meet or exceed those KX modifier therapy thresholds, these are some of the common issues that we are finding. My computer's being slow, so sorry. Okay. First issue is lack of or missing documentation, which basically means that providers are not submitting all of the documentation required. On our website, we have a list of documentation that needs to be submitted for review. And I'm going to jump back to our website for a second, and I'm going to show you where to find that. Okay, I'm going to go back just to the general page. But under Topic Center, I'm going to go to Medical Review, and I'm going to scroll down to the Targeted Probe and Educate. And I'm going to look at the Targeted Probe and Educate review for outpatient therapy services. And here we list the documentation that we are requesting when we, do review of the claim. This information is also on the ADR request, and if you were to have a post-pay medical review, it would also be listed on your review letter. Change back and show you the slideshow again. So again, that's where you can find that information. Also, the Benefit Policy Manual on CMS's website. And that manual is 100-02, Chapter 15, Sections 220 and 230 are all things outpatient therapy. So documentation requirements don't change just because the KX modifier is appended. And by that, I mean that just because you attest to the fact that continued services are medically reasonable and necessary in your opinion, it doesn't mean that you don't have to continue to support that in your documentation. Remember, part of the KX modifier use is actually attesting to the fact that you indeed have the documentation on file to support the services. In the next few slides, we're going to discuss which components of documentation are generally the biggest offenders of not being included or not containing the correct information. But what is here on this slide are some general documentation components that are often missed. So evaluation and including any necessary reevaluations, plan of care, certified plan of care, and any necessary recertifications, progress notes, treatment notes on a daily basis, and an ABN if it's necessary. So let's talk about progress reports and the issues that we see regarding the progress report. So a big component of documentation that sometimes we don't receive is the progress note itself. Remember, a progress note must be completed on or before every 10th treatment day. You can do it as often as you want, but it has to be done on or before every 10th treatment days. Progress notes must be written by a therapist. Remember, it is, again, required on or before every 10th treatment day, and the therapists themselves need to formulate the note. And the reason is this note summarizes your patient's progress from week to week. It also helps anyone and everyone that looks at that chart to see how your patient progressed since the start of care. We use the progress note as a means to see the patient's progress towards goal in a quick and concise manner. If a goal is no longer relevant and needs to be changed or it hasn't been achieved, we look to the therapist to show these things in their documentation. A therapy assistant cannot write a formal progress report. They can assist you with some of the aspects of what they have observed throughout their time with the patient, and the therapist can use that information when they're formulating the progress note, but the progress note itself cannot be written by the assistant. If an assistant writes a progress note, it will be viewed as the information was not received because we can't, that doesn't meet the program requirements of who can and cannot do a progress report. So again, it would be lack of documentation on your part because that progress note was not written. It wasn't written by the right person. If it was written and signed by the therapy assistant, or sometimes we just don't even get them. They forget to submit them. As we move on, the next component of missing or incomplete documentation is regarding the physician certifications or recertifications. Remember, in outpatient therapy services, an order for therapy is not required. However, a certification is. So it's a Medicare requirement that the beneficiary be under the care of a physician. So how do you prove that? You prove that by obtaining that initial certification and then when necessary, any recertifications. So just a little bit about the certification, recertification timeframes. The initial certification is required as soon as is reasonable and practicable. So what that really means is you have to get the initial certification within 30 days of treatment. Your certification is then good for 90 days or the average length of the certified plan of care. So if you sent your plan of care to the physician and you said you're going to see the patient 3 times a week for 3 weeks, that means it's only good for 3 weeks. Or if a billable formal reevaluation has to be completed. So again, 90 days or the length of the certified plan of care, or if a billable formal reevaluation needs to be completed. If the provider does not sign the certification, it's not complete. Therefore, there's no certification on file. So the benefit manual, benefit policy manual, again, that's 100-02, Chapter 15, Section 220.1.3D as in dog. It does allow, in rare instances, for a provider to do a late certification or recertification. However, part of that condition of that being allowable for coverage is that the physician writes a justification statement of why the certification or recertification was late. And it specifically says delayed certification and recertification requirements shall be deemed satisfied where at any later date a physician or MPP makes a certification accompanied by a reason for the delay. Honestly, in my time in the medical review department, I saw that once, that we got adequate justification for late certification. So remember, if you are chasing a physician trying to get certification and you've exceeded the time frame, but you are getting it or you have found a way to get it from that physician, make sure they write a justification. Also, remember that you are documenting every single attempt that you have made to obtain that certification or, when necessary, recertification. So remember, Medicare is a physician-directed program. So we require the physician involvement to meet the basic requirements of service. When we have to verify that services beyond those therapy threshold limits continue to be medically reasonable and necessary, we must make sure that all required coverage components are met. So again, no signature, lack of signature could prohibit payment of your services. All right. So besides standard components of documentation missing or not being submitted, documentation can also be lacking by not adequately documenting the why of the continued need. Why do the continued services need the skills of a qualified therapist? Why can the services only safely and effectively be rendered by that skilled therapist or under the supervision of that therapist? What services does the patient continue to need that are skilled? Are those services helping the patient to reach their goals? What are the goals? Have the goals been updated? Has the skilled therapist adjusted the services to meet the needs of the patient for the goals that they're not achieving? So these are types of questions to ask yourself as a therapist for any patient that you intend to render skilled services for. However, when it comes to the KX modifier, it's of utmost importance that you are making sure you are answering these questions. First and foremost, as the therapist, why does the patient need me, my skill set, my licensure? Can someone with no license in PT, OT, or SLP services provide what the patient needs? If they can, then it probably isn't a skilled services. So again, part of the issues on review are documentation not supporting that continued need. And finally, this kind of goes with the last issue, but vague justification of medical necessity. Medical necessity. When you're trying to justify the medical necessity of services, the last thing you want to do as a provider is to be vague about the reasons for continued care. However, when reviewing documentation that has the KX appended to it, that's what we're often getting. So documenting the diagnosis or supporting that the service is administered by a qualified therapist or a therapy assistant doesn't mean that the service is medically necessary. Look at the diagnosis of MS. I have MS. I work out in a gym almost every single day by myself. My diagnosis doesn't define my need for therapy. Are there times when I have exacerbations that require me to have therapy services? Absolutely. But those changes to my current condition would then justify the reason for therapy, not the diagnosis alone. Also, just because a goal is not met doesn't mean that continuing therapy services for long periods of time is medically necessary. This is when the skilled therapist should be looking over the patient's plan of care when they're doing their progress notes and determining if the goals are still reasonable for that patient. Perhaps the goal needs to be modified. Perhaps it was never even realistic for the patient to achieve that goal. All right, and then I just want to talk just a little bit about maintenance, why we have a few minutes left. So if you are providing maintenance services for your patient, so you're providing skilled therapy services to prevent or slow a patient's decline or deterioration process. The goal is to maintain as much functional status as you can. This doesn't mean that the providers just put someone in a program and call it maintenance and provide therapy one time a week with the justification of the patient does better when they're with us. I do better when I'm in front of a trainer. And of course, I'm going to push harder. I'm going to do better. I'm going to excel greater. But it doesn't mean I need a trainer. And it doesn't mean I need a therapist. So when you are doing maintenance services, a thing to think about is what specific goals are you trying to achieve? What skilled modalities of service will be rendered to help your patient achieve these goals? Take again, for example, the MS patient who has chronic progressive MS is now having increased gait and balance issues since their last discharge from PT services. In order to prevent or slow the deterioration, it's necessary to assess for some assisted devices, possibly braces, and teach the caregivers some carryover to use, and maybe assess for some safety in the home or, et cetera. A plan of care is established by the therapist. You set your goals, you do your evaluation to determine, and maybe you determine during that the patient needs some AFOs to be fabricated and a walker or other assistive gait devices. Those are going to be introduced as well. You decide on the type, of maybe walker assisted device that'll be used, and then you start working with the patient when the AFO comes in and make sure it's fabricated okay, make sure the fit is good, make sure that the patient and any caregivers are learning how to put it on properly, take it off properly, how to walk with it, etc. And then you get out. Because they're going to come back at some point. They're never going to get back to their prior level if they have a chronic progressive, disease that is going to continue to get worse. But you want to get them the best that they can get for now. You introduce the things that they need. You make sure they're okay with the skills. You're trying to slow or prevent. you do some therapy, you do lots of education, and you let them go. So when we do see documentation for justification of medical necessity for maintenance programs, it's really important that you are documenting all the information that you can of what your goals are, what you're trying to prevent. You're showing us those skilled interventions that you are doing. All right, and now let's recap. We've gone through a lot of information in a short period of time. So hopefully now you're equipped with the knowledge and some of the tools necessary to ensure proper billing and compliance with your outpatient therapy services for when you should report the KX modifier. So we've achieved this by discussing what the KX modifier is, its purpose in outpatient therapy, and then we reviewed how and when to report the KX modifier and therapy services and where you should look to see if the patient is meeting those threshold amounts that you have to append that KX modifier. And we also highlighted some common documentation errors and areas of just general overall concern. So that's going to take us to the question and answer portion of today's call. So at this time, I am going to ask, or before I ask Rachel if we have any further questions, I do want to discuss one more pre-submitted question. So someone had sent in a question about the use of the KX modifier on the HCPCS code 97039. The 97039 is used to report procedures in which the provider uses physical therapy modality that does not have a specific code. In this case, if the reported HCPCS code is appended with a revenue code, such as a 42X or a 43X for OT or a 44X for SLP, the KX modifier would have to be reported on those claim lines if the beneficiary is at or above that threshold amount. So at this time, I am going to ask Rachel if we have had any questions that have come into the chat.
Yes, we had one come in. I think that would be good to address for the group. So the question's from Michelle, and it is, does the therapy caps apply to Medicare Advantage?
Well, that's a great question, Michelle, because we don't know all the Advantage programs regulations, rules and regulations. So unfortunately, if you do have the Advantage plans that you work with, you are going to need to turn to them and ask that information if they need the KX modifier appended to their claims. All right. Were there any other questions, Rachel?
No, that was it.
All right. This is some resources that we provided in the links in the chat today, but it's also on your slide deck just in case that you need them or you want to refer back to them later. So Rachel, have any other questions come into the chat?
No, not at this time.
Okay, thank you. On behalf of all of Provider Outreach and Education, as well as our Medical Review Department, I would like to thank you for your participation in today's event. We look forward to your survey comments and especially your suggestions for future education. So please continue to watch our live events page on our website for those future educational events. And you may now disconnect.